Hello everyone, I'm Dr. Ng. Today I'm going to talk to you about how to plot a partogram. The outline of this tutorial will include the 5WH question, which is what is a partogram, why do we not need to plot a partogram, when to plot, who needed a partogram, and how to plot and interpret it. Okay. So partogram is actually a diagrammatic representation of the progress of labor. So it tells the story of the patient in labor, and the main components includes the progress of labor, maternal condition, fetal condition, and the drugs given. What do we monitor on the partogram? We monitor fetal heart, we monitor molding like core. We also monitor the descent of the fetal head. This gives you an idea of the relation of the passage and also the passenger. And also we look into VEs. We monitor the contraction. Contraction will tell you the power and drugs that we give. We look into the maternal vital signs and also the urine. So why do we need to do a partogram? Okay, if imagine you are a houseman who came to work in the morning, you are a morning shift houseman, you have this lady who is in active phase of labor. So at 8 o'clock will be her, she has 1 in 10, os is 4 cm, and then review in 4 hours time. She didn't manage to go down to labor ward because the ward is full, so she was monitored in the maternity ward. At 12 o'clock, 4 hours later, okay, you reassess her, she's 5 cm, her contraction has increased to 3 in 10. Alright, yes, there is some progression. Alright, so you wanted to review her again in 4 hours time. So at 4 o'clock, you review her, she remains 3 in 10 and also os is still 5 cm, but it is your shift finishing already. So you're going to pass over to your friend. So this is what happened. Most of the time, you just pass over, oh, we have a patient who is in active labor, she's contracting 3 in 10, 5 cm. So her next review is at 8 o'clock. Then your friend will only come and see her at 8 o'clock. So this is what happened. So at 8 o'clock, contraction is 3 in 10, os is 5 cm still. So this poor guy go down to labor ward and present the case and say, oh, I have a patient who is os 5 cm. But never knowing that, can you see on the partogram how it is? So this actually, if you plot a partogram, you will be acting very early. Even from 12 o'clock, you should act already because this is a primary dysfunctional labor. So I will talk to you about primary dysfunctional labor later. This is why you need to plot partogram. You want to monitor the labor progress. You want to monitor the mother and the baby. You want to avoid undiagnosed labor dystocia or prolonged labor. And it also gives you an overview of the 3 P's, which is the power, passage, and passenger. In the power, it will be portrayed at the contraction part. And the passage and passenger, you will be able to pick it up at the labor progress as well as the descent of the head and also the presence of molding or not. When should you plot the partogram? If patient is in labor, here I mean is active labor, and those that who have induced with oxytocin will require a partogram. So first of all, you need to know what is a labor. The definition of labor, it has to consist of these 3 things, which is regular painful contraction, which is in increasing intensity, frequency, and duration, with cervix dilatation and effacement, and also descending of the presenting part. Alright, and the stages of labor, you need to know what are the stages of labor. So first stage includes when the onset of labor until os full, and second stage is os full until delivery of the fetus. So if let's say you have twins pregnancy, is until the second baby came out. So third stage of the labor is after delivery of the fetus until delivery of the placenta. Okay, so we are going to focus mainly on the first stage of labor, and it divides into active and latent phase and active phase of labor. Alright, so this is the partogram that you usually see. Okay, it contains all the information and we'll go step by step on how to plot it. So first of all, you need to see, okay, it's very important for you to write the patient's identification, the name, and fill up the gaps, the age, gravida, parity, and all, and the date of admission, time of admission, and all. Alright, and it also important to write the risk factors of the patient on the top right. Okay, for example, in this case, we see it's a 30 years old, G2P1, 37 weeks, we have preeclampsia and previous scar. Just a simple summary like that. And then we do also write down the FPC and the GSH on top of the chart. Okay. So next we go to the fetal heart rate. Okay. So this is how you're supposed to plot the fetal heart rate, and according to the timeline. Okay. If you notice at this point, all right. So at this area, this is the line representing 8 o'clock. All right. This is the line representing 9 o'clock. Okay. So let's move on to the LIQUA and also the molding. So if you look at the LIQUA, all right, if you have ARM, the patient, then you write ARM here, and then you write down what is the color of the LIQUA. Is it clear LIQUA, or is it a slight meconium stain, or is it a MMSL or a TMSL? All right. As for molding, what is actually molding? So sometimes you see somebody write 0, somebody didn't write at all. Okay. So this is what actually a molding. Molding is actually overlapping of the fetal sutures. So if you see, if there is no sutures, the parietal bone, this is at the midline is called the sagittal suture. So they are actually not touching each other and they are not opposed, meaning that the fetal scalp is in a such way that when it has to go through a very narrow area, they can squeeze it and they can overlap it so that it can reduce the biggest diameter of the head to pass through the pelvis. So this is called no molding when the parietal bone, you did not feel that it is touching each other. Molding is 1+ when the parietal bone touch each other. It is 2+ when it overlaps but it is easily reduced. And then it is 3+ when it overlaps and you cannot actually push the suture back. All right. Okay. So it is, if 3+ is a signs of obstruction. So next we go into this. I think most of you will only just plot this area, which is not supposed to be like that. So if you see on the top left, you have the cervix, which you have to plot X. And descent of the head is actually head per abdomen. It is not station. So head per abdomen, you have to plot as O. All right. So let's look at here. You have a patient at 8 o'clock in the morning. Her head per abdomen is 3/5. Os is 2 cm. Station is -2. Okay. So this is how you're supposed to plot. Okay. Os is 2 cm. All right. Then the head per abdomen is 3/5. And you write down the time: 8 o'clock, 9 o'clock, 10, 11, 12. Okay. So the station doesn't really matter here. Okay. Next is at 12 o'clock. The head per abdomen is 1/5. Os is 6 cm. Station is 0. So this is how you're supposed to plot: 6 cm here, and then you have the head per abdomen 1. Okay. So at this point of time, it has shifted from latent phase to active phase. So where should you plot this thing? Okay. A lot of you will actually plot at this line, which is not supposed to be, and I don't understand why, but you're actually supposed to draw on this alert and this alert line. Okay, so this is how you're supposed to draw. Put the X over the alert line at 6 cm here, and then you copy this one, head per abdomen 1/5 over here, and this is the dot line that you put, and then you shift the timeline over here at 12, 13, 14 hours. Okay, and then subsequently at 2 o'clock, head per abdomen is 0/5. Os is full, so Os full 10 cm here, head per abdomen 0/5 here. Okay, so if you plot the head descent of the head by station, so station is +2, where do you want to plot? No place to plot, right? Okay, so this is how it's supposed to be okay. So you need to know what is a primary dysfunctional labor and what is a secondary arrest. Primary dysfunctional labor is when initially there is progress of the labor, and then subsequently there is inadequate progression because of inadequate contraction. So if you want to say an adequate progress is at least 1 cm in 2 hours. So if you see there is a delay here, and because of the contraction is ineffective. All right. So the other thing about this action line and alert line is you always start from this alert line when you are in the active phase, so that 4 hours later you will see, or 2 hours later you will see. Once you touch the action line, it does not mean cesarean section. Action line means you need to take action okay. So let's look at this, the second example. So at 8 o'clock in the morning, head per abdomen is 3/5, os is 4 cm, station is -2. So this is how you're supposed to plot. 4 cm already, so you straight away come to the alert line because it's active phase already. Okay, so plot here, not here, so it is here, huh? And then the head per abdomen is 3/5. Okay, so you put down the timeline. Then subsequently, 4 hours later, you review, head per abdomen is 1/5, or 8 cm, station is 0. Okay, so this is where you're supposed to plot 8 cm. So the head per abdomen is 1/5. Okay, so then subsequently, you review back in 2 hours time because from 8 to 10 cm is 2 cm apart, so you expect 1 cm per hour, so you review back in 2 hours later. So at 2 o'clock, you still have the same findings. All right, so what do you think about this? Okay, many of you may say it is a secondary arrest, but you have to be a bit careful. Is the contraction optimized? And you also have to know whether there is any signs of obstruction. But at your level, we are not expecting you to be able to manage much about this. Okay, some of you may say, oh, she need a cesarean section, but you need to look at the overall picture. So secondary arrest means that the labor progress was arrested at usually it's around 7-8 cm, whereby the cervical dilatation and descent of the presenting part has stopped despite good uterine contraction. And this is always due to either absolute CPD, cephalopelvic disproportion, or relative CPD. How you will know? You look into whether there's any obstructive signs or not. So these are the evidence of obstructed labor. So if you see the patient has large caput, has third degree molding, which is 3+, or the presenting part poorly applied to the cervix, or the cervix or the vulva or vagina is grossly edematous, or there is maternal fetal distress, those are signs of obstructed labor. Okay, so next we go to contraction and about oxytocin. So if you see, you have to know mild contraction means less than 20 seconds. Moderate is 20 to 40 seconds. More than 40 is strong contraction. So if let's say you TCM the patient 1 in 10, 20 seconds only, so it falls under this moderate. So you need to shade it like this. Okay, so this is how you do. Let's say this is 2 in 10 minutes mild. Okay, so this is 3 in 10 moderate, this is 4 in 10 strong contraction. But how about if it is just 5 boxes? If you have 6 in 10, then how? 6 in 10 is abnormal. So that is tachysystole or hyperstimulation. You need to alert the your MO, or if you see the patient is on oxytocin, you need to off the oxytocin. Alright. Next is about the oxytocin. If you realize it is written here units per 500 mils and drops per minute, but we have changed our policy. We have changed it to 10 unit in 50 cc, 49 cc normal saline, and we run at 0.3, 0.6. You can find the chart in the label ward. So this is how you write 10 unit, then you write 0.3. This upper half is we supposed to titrate the oxytocin every 30 minutes. So this is at 8 o'clock to 8:30, we infuse 0.3 mils per hour. Then subsequently at 8:30 to 9 o'clock, we infuse 0.6. This is how you are supposed to plot your partogram. Okay. Then you also have to write down what are the fluids that has been given and what are the medication that has been given. Okay. So next will be the pulse rate and the blood pressure of the mother. So this is easy. The arrow is actually this is systolic blood pressure, this is diastolic blood pressure, and this is the heart rate. Okay, so in a patient with hypertension, you would like to monitor closely. Every hour you need to do the blood pressure. Otherwise, if low risk pregnancy, you can do it 4 hourly. Okay. And the temperature, you will need to monitor the temperature as well, especially in those patients who has rupture of membrane or leaking. Okay, so this urine albumin. Okay, sugar and ketone, we do not have the strips in the label, so we do not routinely do now. So but you have to document how much is the urine that patient has emptied also lah. After you have plot the partogram, during the rounds, you will need to present. So you just need to actually refer back to this piece of partogram, then you will be able to present and give a summary of the case. For example, this is Madam ABC. She's at 30 years old, G2P1, currently 37 weeks, preeclampsia, one previous scar induced for preeclampsia toxemia with an estimated fetal weight of 2.4, 2.6 kilo. She has been in the labor ward for the past 2 hours. We have ARM her at 8 o'clock in the morning, which shows clear liqua, and her constriction was inadequate. It's 2 in 10 mile. She was 3 cm, head to abdomen was 2/5, sorry, and she was started on oxytocin of 0.3 mL per hour, and she was kept fasted with a drip of 80 cc per hour. Her vital signs for the past 2 hours has been normal. Currently, she has obtained good contraction, which is 4 in 10 strong. So far, fetal heart activity, fetal heart is within the normal range, and then you can say CTG is normal or not. So our plan on her is to review in the next review in another 2 hours, which is at 4 hours after the ARM, which is at 12 o'clock. This is how you should give a summary of the partogram itself. So do this when you are doing rounds, don't go missing. Okay, come and follow the rounds during the labor ward or antenatal ward or even gynae ward. Okay. All right, with that, thank you.